I'm Shonni Silverberg. I'm going to be talking to you today about primary hyperparathyroidism. It's a huge topic. There will be gigantic holes from my point of view in this talk because basically I have devoted the last 35 years of my life to studying this disease, and I'm going to describe everything we've done in 45 minutes standing on one foot. But anyway, so I'm here. All of you have walked by my office a million times. So if there are questions, hopefully we may actually have some time at the end since we're starting early, but also I'm available to answer questions while you're here. So I have no disclosures, and I will be talking about bisphosphonates and off-label use. So when I went to medical school, I learned about primary hyperparathyroidism as a disease of bones, stones, and psychic groans, which is how Fuller Albright described the disorder in the 1930s. And that disease is really pretty much disappeared from the landscape in the US, although not around the world. And osteitis fibrosa cystica, which was the very specific skeletal disorder that was associated with salt and pepper skull, resorption of the distal phalanges and clavicles, brown tumors, is something that is seen occasionally, but only very occasionally, and many of you may never get to see a case of it in your careers. We started studying the disease in the early 1980s. Dr. Bilezikian had been studying it for a while in the 70s. But basically what you see here is a characterization where a disorder that mainly was characterized by kidney stones and bone disease in its early characterizations came to evolve into a disorder in which most patients were asymptomatic, and we'll talk about what that means. And those patients who were symptomatic with nephrolithiasis. Hypercalciuria is something that was never reported or measured in early studies, and so that data is not available, but it does look as if the studies where urinary calcium was measured, that has not significantly changed over time. What happened really was that in the 1960s and 1970s, the multi-channel autoanalyzer came into being, and all of a sudden physicians who were interested in their patients' cholesterol or glucose or creatinine started getting calciums as a freebie, not something that they were interested in particularly, and started noticing that there were patients who had calcium elevations without the classical symptoms that they had come to expect in disorders of hypercalcemia. And of course, the initial reaction was obviously these people must have malignancy, the other main cause of hypercalcemia. And as these workups were undertaken to uncover a deadly disease, the non-deadly primary hyperparathyroidism was instead discovered, and for the first time, asymptomatic hyperpara was noted. The question then was, what was going on? And was this a different disease, a new disease? Was this just an early form, as occurred with the inception of pap smears, where you just all of a sudden seeing a disease at a time point much earlier in its development than you would have otherwise, and that if these people were left untreated, our hypothesis was that they would develop into the more classical, more severe, clinically overt primary hyperparathyroidism that we had come to expect. With the classic target organs being the kidney and the bones, we were wondering whether or not kidney stone disease would have a similar or lower incidence as we followed people over time. And then the other major question was, is the skeleton no longer a target organ of primary hyperparathyroidism because no one was seeing osteitis fibrosa cystica anymore? And just coincidentally, at about the same time, bone densitometry came into being. At that time, actually, it was single and dual photon, but mainly single photon, and then subsequently the dual photon studies with ultimately DEXA, enabling us to look at different parts of the skeleton that had different admixtures of the two types of bone, cancellous and cortical bone, allowing us to ask questions about the end result of having excess parathyroid hormone. So prior to thinking about it within the context of our studies, Mainly people were interested in bone densitometry because of osteoporosis, which affects postmenopausal osteoporosis, which mainly affects the lumbar spine, having more cancellous bone, which is the first one that is affected by estrogen deficiency, and then subsequently the hip. We knew that the one-third radius, which is made up mainly of cortical bone, the distal one-third radius, we hypothesized that that would be the most severely affected because it had long been known that parathyroid hormone was catabolic in cortical bone, thus the resorption of those distal phalanges in the areas that were affected in osteitis fibrosa cystica. So it was our hypothesis that the one-third radius was going to be affected, and we really didn't think terribly much about what would be expected in the rest of the skeleton. However, the demographics of the disease as it was presenting was at least half of all patients were postmenopausal women, with the balance being divided between premenopausal women and men. And so because of the preponderance of postmenopausal women, we assumed that they would have sort of a double whammy with badness due to menopause in their spine, and then badness due to the hyperparathyroid process in the one-third radius. And what we found, at least confirming the hypothesis, was that in the one-third radius, as shown in the red bar, there was a decrease in bone density. What we had not really thought through, and certainly had not expected, was that this group, which again is mainly postmenopausal women, would have pretty good bone at the lumbar spine. And the hip was intermediate between the two. So again, the diminution of bone or the preservation of bone, if you think about the emphasis on different syllables, depended on the amount of cortical bone at the site that was measured. This graph comes from our cohort as a whole, but the graph of postmenopausal women alone looks exactly the same. So they too have their best relative bone density at the lumbar spine and the worst at the one-third radius, a picture completely opposite of what would be seen in somebody who had severe postmenopausal osteoporosis. So we went on to look histomorphometrically to see what was going on, and I am not a histomorphometrist, but I love these pictures because even I can see most of what we're trying to show. And these are samples from two individuals who are age, gender, and menopausal status matched, and it is easy to see with the naked eye that the cortices are markedly thinned in the primary hyperpara sample versus the normal sample on the top. What is a little less easy to see with the naked eye, but is clearly the case when more advanced studies were done, was that the cancellous bone volume was actually increased, and that the connectivity of the trabecular plates within the cancellous compartment was also greater. So these trabeculae were not only increased in volume, but they were more connected one to the other. And that the normal and expected age-related decline in trabeculae was not seen. So often what happens is the trabeculae thin out, and then the plate will become broken and then ultimately disappear over time, was not happening in patients with primary hyperparathyroidism. So what we were wondering is whether or not there was an association between our bone density findings and the risk of fracture, and what was the story with fracture in patients with primary hyperparathyroidism. So you've seen this many times certainly since coming here, and probably prior to that as well, and know that the association that is described with that wonderful -2.5 describing osteoporosis is a relationship that was described in Caucasian women without primary hyperparathyroidism. These are in a group of normal and osteoporotic women. The first thing to say is that we have absolutely no idea whether or not this relationship holds in the same way in patients with primary hyperpara. That is to say nothing about FRAX. So we have absolutely no idea whether the predictions that FRAX makes apply to patients with primary hyperparathyroidism. So the two most commonly used yardsticks, which are obviously the minus 2.5 cutoff and the minus the osteopenia description from the World Health Organization, and then the FRAX, which sort of builds upon that, none of those have ever been looked at with regard to patients with primary hyperparathyroidism specifically. We assumed from what we knew of the bone density and the histomorphometry that cortical bone would be at increased fracture risk, and therefore the sites of bones that contain mainly cortical bone would be at increased risk. But we didn't really know what the story was with cancellous bone, although it was clear that many of the observational studies that existed suggested that fracture risk was increased there as well. And in this study, for instance, of 407 patients with primary hyperparathyroidism from Rochester, Minnesota, Sandeep Khosla described fractures at all sites, or at many, many sites. And as you can see, all were increased relative to patients without primary hyperparathyroidism. And in a specific study that only looked at vertebral fracture risk using 150 hyperpara patients and twice as many non-hyperparathyroid healthy control women, we found, Vignali et al. Found a significant increase with vertebral fractures in 25% of the hyperpara women versus in 4% of controls. So the question came up, how do we explain this discrepancy? Actually, on histomorphometry, and they look better than normal, and yet there is evidence that they have more vertebral fractures, which are the sites of interest in terms of the preservation of the lumbar spine bone density. So as you've been hearing again all week or week and a half, as long as you've been here, that there are other aspects of bone quality that clearly contribute to bone strength aside from bone densitometry, the microarchitecture, the rate of turnover, the geometry, the bone size, the mineralization and matrix and mineral composition as well. And what we know about primary hyperparathyroidism does go a certain distance to explaining the discrepancy in terms of what we've seen. Now, with this group, I don't have to go into this in great detail. I am often speaking on the first day of this course, in which case you've never seen an HRPQ-CT. As you now know, probably better than I, HRPQ-CT assesses size and volumetric density as well as microarchitecture, and can do so of the specific skeletal compartments, taking the trabecular and the cortical separately and looking at them differently. And so it was a wonderful and exciting potential technique for us to look at people with primary hyperparathyroidism. And here again is the explanation that you've already received in a more eloquent fashion from people who actually do this for a living. So, and know that really people who have the very same DEXA reading can have widely discrepant values by HRPQ-CT. And what we found with the HRPQ-CT was that there was significantly worse indices, both of trabecular and of cortical bone using HRPQ-CT in patients with primary hyperparathyroidism, and that so many of these have downward arrows reflecting worse, but those with upward arrows have to do with the trabecular separation. If your trabeculae are farther away one from the other, there is less bone to provide mechanical competence, and the strength is also decreased, and subsequently failure load as well. At the tibia, the findings were somewhat less profound, but still trabecular indices were decreased. So the resolution of the paradox seems to be that the resolution of DEXA is not really sufficient enough to identify the microstructural trabecular bone loss, and that the bone biopsy may be discrepant because the iliac crests may not be necessarily representative of the sites that are affected in primary hyperparathyroidism. And one of the morals of this story seems to be that diseases don't affect all bones in different skeletal locations in the same way, which I think you may have been hearing in other contexts over the course of this week from other people. And HRPQCT gives it some data about a compartment that may be more relevant to fracture risk in primary hyperparathyroidism. So DEXA is used because it's readily available. HRPQCT is not readily available. It's a research tool and will not become readily available. It's just too expensive. We use the DEXA data with the understanding that at least at the lumbar spine, it may not be a great predictor of fracture in people with this particular condition. TBS is something else that you have already heard about. Again, I'm usually explaining this for the first time, but you all know about it and know that it is a procedure that can be done on lumbar spine bone density studies, and it was something that we were very hopeful was going to give a better and cheap way of using the DEXA, which is widely available, to give information about primary hyperpara. And in fact, what we found is that the TBS in patients with primary hyperpara as a group is in the partially degraded range, so it at least does seem worse than the very well preserved bone density, and that is in individuals who were largely, 53% were entirely normal, not even in the osteopenic range by bone density. And as you can see in the upper left panel, the T-scores in these patients were -1. I mean, they were better than anybody has a right to be, and yet were partially degraded on TBS. Fracture data in using TBS also suggests that the TBS is lower in patients who had vertebral fracture, despite the fact that there was no difference in lumbar spine bone density between the groups of the vertebral compression fractures versus none. So suggesting that using TBS may provide valuable additional information in individuals where HRPQCT is not available. And again, as I said, it will not be in most centers. TBS also was found to improve after parathyroidectomy, and we'll talk a little bit more about that later, with a z-score going from -3 to -1.5, really, in patients after surgical cure. So as regards the bone and primary hyperparathyroidism, DEXA and bone density don't clearly explain the prevalence of fracture at trabecular sites. HRPQCT does do a much better job at capturing the changes in trabecular and cortical compartments both, but it is unfortunately not widely available. And TBS correlates with HRPQCT, making it a possible source of greater amount of information for individuals who only have DEXA available. So our hypothesis at this point is that both trabecular and cortical bone are compromised in primary hyperparathyroidism, and there is a whole body of research just looking at further elaborating the nature of this compromise. There are, in addition to the bone, the kidneys are the other classical organ, and it is clear that kidney stones remain, as I mentioned before, the most common overt sign or overt clinical feature of primary hyperparathyroidism, but that is only in about 20% of cases. What about other non-classical manifestations of primary hyperparathyroidism? And in individuals who had the disease that was described by Fuller-Albright, there were many, many organ systems that were affected by the hyperparathyroid process. It shouldn't be surprising when we think that, in fact, most of Fuller-Albright's patients, the group that he originally described, his cohort from Mass General, had a mean serum calcium in the 12 to 13 range. And so if you have calciums that are that high, the calcium doesn't have a map that says precipitate in the kidneys but not elsewhere. And in fact, pretty much every organ system was involved. And there were clearly neuropsychiatric, behavioral, cardiovascular issues that were seen in those individuals. We now add things that they were not able to measure, like vitamin D deficiency and the new, or not so new anymore, but certainly would have been unthinkable, normocalcemic primary hyperpara in the time of Fuller Albright. So in terms of the neuropsychiatric manifestations, the question comes up on a regular basis, are all patients actually symptomatic? And certainly many of our surgical colleagues would argue that every single patient with primary hyperparathyroidism has some symptoms, and in particular they point to the neuropsychological symptoms in that regard. And any of you who have taken care of patients with primary hyperpara know that many patients with the disorder complain of weakness and easy fatigability, which may actually be the most common complaint. Some complain of depression, others of intellectual weariness, and others of increased sleep requirement. The problem with this is that I am a postmenopausal woman of about the age that many people are who have the diagnosis of primary hyperparathyroidism, and there is not one thing on that list that I don't have at least some of the time. They don't characterize my life every day, although the easy fatigability probably does. But they're so common, and whereas kidney stones and broken bones and osteitis fibrosis cystic are easy to draw a line from hypercalcemia, hyperparathyroidism to those symptoms, these are much more difficult, and they're also harder to quantify. And patients themselves often don't know if this is just what getting older is, or if this is something that's associated with something else. And actually, one of the things that has been most frustrating is that there actually has been good science thrown at this. There's been a ton of bad science thrown at this. The bad science being, are you anxious or depressed, and as a question before surgery, and then those people who are cured after surgery were less anxious and depressed, and those people whose surgery was unsuccessful were still anxious and depressed. But of course, drawing a line from that to primary hyperparathyroidism as opposed to your surgery didn't work is very difficult. But we were hopeful that the randomized controlled trials of primary hyperparathyroidism, in which people were randomized with very mild disease to surgery versus observation, might be helpful. And in the 3 that exist, all of which are small and not particularly highly powered, and all thankfully using the same vehicle, the SF-36. They each did use some other ones, but this is the one that went across all of the studies. What we found was that there was a benefit to surgery in terms of primary hyperparathyroidism, but if you lived in Detroit, it had to do with social functioning and emotional problems. If you lived in Italy, it had to do with bodily pain and vitality. And if you lived in Scandinavia, it was physical function, and your mental health got better for a year, but then it got worse again. So to me, this is the epitome of something that you can't really point to. You have someone sitting across the desk from you, and you cannot say, you are going to get better with regard to this, or you are going to get better with regard to this, or this is not going to change because this is not great. This is good science in theory. The outcome was not good in terms of allowing people to predict what's going to happen in a given individual. We were frankly dismayed and unhappy and upset and cowed by the prospect of doing studies that were looking at some of these softer symptoms. And so Dr. Marcella Walker and I designed a case control study of postmenopausal women that would take psychiatric symptoms into account, but point and more directly towards areas of cognition that were easier to get your arms around. This was complete cowardice. I mean, we were interested in this, but we also felt that unless we could get sort of some harder areas to study, that it was going to be that we were running the risk of having the same outcome as had happened before. And so we did a very wide battery of cognitive and psychological testing. Again, there had been previous studies that had said, yes, there are cognitive and memory effects, but they only looked here. And then another one would come out and say, no, there absolutely are not, but they each only did one study of cognition or memory. So we decided that what we had to do was sort of, be very broad and not have a preconceived notion about what this was going to show, and then do that whole broad battery in a large group of menopause matched and age, gender, menopause matched individuals, and control also for depression and anxiety, education and IQ. The latter two, surprisingly and amazingly, had never been controlled for in any of the previous studies, although it's well known that education and IQ are confounders of many of these kinds of studies. And what we found was that the patients with primary hyperparathyroidism, who are shown in the black bars, had more depression and anxiety than controls. And 6 months after surgery, shown in the second set of bars, depression was indistinguishable from controls. Anxiety, trait but not state anxiety did decrease, and I can't explain the latter. The limitation of this particular study, again, is that we didn't have a surgical control. So again, we can't say for sure whether the improvements in psychological symptoms are due to the fact that they no longer have the disease on their mind weighing on them. On the other hand, the cognitive function also showed impairment with relative to controls and improvement, and those cognitive findings should not have been something that got better just on their own or in association with surgery, unless there was some sort of association. And the important findings were that they were specific. So it wasn't that everything was worse than controls and everything got better, but verbal memory, both immediate and delayed, was clearly worse than controls at baseline. And although we controlled for this statistically, it is also worthy of note that the primary hyperpara patients were more highly educated and had higher IQ, so one would have expected better scores in them. And that by the time the 6-month follow-up was done, they were indistinguishable from controls. Similarly, nonverbal abstraction was worse at the time of enrollment and better 6 months later. Importantly, there was no difference in visual concentration or visual or memory, and auditory attention and mental manipulation, the ability to do math, was not any better. So again, suggesting that there is some specificity in terms of the issue. So we conclude that there is some impairment in quality of life issues, that psychiatric and cognitive abnormalities are part of this mild condition, but the data on reversibility are such that I never send somebody to surgery because of this. When I have somebody who has neuropsychological conditions, I say to them, a positive benefit of your surgery may be that X, Y, and Z will get better or go away, but that can't be the reason to do it, because I have no way to predict whether or not it's going to get better 0, 25, 50, 75, or 100% in you.
What about male patients?
What about?
Male patients, was there any study about?
So there hasn't been any study specifically done on men in terms of now, in all of the RCTs, men were included, so those were all comers. Our studies having to do with cognition were only on women. So cardiovascular manifestations were actually very important in the old days. They used to die of heart attack and stroke at rates much higher than the general population. And certainly when you look at the classical studies of mortality, it was clearly increased, and in more modern Scandinavian literature, where the mean serum calcium levels remain higher than they are here, mortality has been increased until the much more recent studies. The only American mortality study that is available is from the Mayo Clinic, and actually found overall no increase in mortality with hyperpara, but specifically a decrease in cardiovascular mortality. in these individuals, which may actually be attributed to the fact that they are followed more carefully or actually be a real decrease in mortality. It is important to know that even in the American study that those in the highest quartile of serum calcium levels did have an increase in mortality. And certainly when you look at the mortality in some of the studies where the relative risk does not cross 1, so that it's actually decreased or increased, there's a sense certainly that as your serum calcium goes up, the mortality goes up, and it certainly looks pretty linear. And when you look at studies that looked at specific cardiac abnormalities in patients with primary hyperparathyroidism, again, you see that in studies that were done where the serum calcium is over 12, many more of them show left ventricular hypertrophy as well as valvular calcification relative to controls. And when the serum calcium was more in the 10s to low 11 ranges, those findings were not seen. We were very interested in this because we were actually seeing the very mildest forms of primary hyperparathyroidism with serum calciums about 0.5 milligrams per deciliter above the upper limit of normal. And it was clear to us that if in fact there were cardiovascular abnormalities that were reversible with surgery, that virtually 100% of people who have this disease should have an operation, because it just seemed that to increase people's cardiovascular risk in that way when there was a way to cure it relatively easily made no sense. So we undertook a study again looking at patients with primary hyperpara. It was 85% women, which is about what our cohorts have. Looking at it against controls from our neighborhood, northern Manhattan. And again, we very broadly looked within the vascular tree because there had again been studies that say echoes are normal, so therefore the cardiovascular system is normal, and others said peripheral vascular disease not normal, and so the cardiovascular disease tree is not normal. And we did not presuppose any location, and we also wanted to look not only at structural changes, which had been looked at primarily up to that point, but with the idea that functional changes may be sort of the equivalent of you see things on DEXA that you don't see on X-ray, that we wanted to look at some functional abnormalities that may occur before you have a heart attack and drop dead. So we looked first at left ventricular hypertrophy, and we found absolutely no increase in either men or in women with regard to hyperpara patients and their left ventricles. And we also found we had a Japanese echocardiographer who was here for a couple of years and who had created a very refined technique not only of identifying valvular calcifications, which has been done for a very long time, but actually of measuring the area of these calcifications, which are shown, and I'm sorry I don't have a pointer, but you can see on the leaflets outlined in yellow each calcification on each valve. So the number of calcifications were not increased in our patients relative to age-matched controls, but the area of calcification was increased. And the area was also found to be associated with level of PTH and not with calcium nor with 25D. So this was a new finding. So it wasn't that the initiation of calcifications was caused by the primary hyperparathyroid process, but if you did have a calcification, it seemed to be propagated more and in association with PTH. We also found that PTH was associated with other functional changes. The first thing we looked at was aortic stiffness using aortic pulse wave velocity, an indirect way of measuring the stiffness of the aorta. And we found that, that having primary hyperparathyroidism was an independent predictor of aortic stiffness and explained 15% of the variance, and that again, how stiff the aorta was in a given patient was associated with PTH and not with serum calcium levels. We looked elsewhere at the large vessels and actually found that the carotid stiffness was also increased in patients with primary hyperparathyroidism relative to controls. And again, Carotid stiffness was associated with PTH, but not with serum calcium or vitamin D. And here you had a large vessel whose stiffness was directly measured, as opposed to the aorta, where we were measuring the pulse wave velocity that came back to the arm. In this case, we were actually measuring the stiffness and the distensibility of the carotid directly using carotid ultrasound. Similarly, we found an increase in the IMT, the intima media thickness, which is a structural change in patients with primary hyperparathyroid versus normal. And again, that although carotid plaque itself was not more common in patients with primary hyperparathyroidism, if you had plaque, the thickness of the plaque was significantly higher in patients with primary hyperparathyroidism relative to control, again suggesting that if this is a process that starts in a patient who has this, the process or the hyperparathyroid process makes the other proceed more quickly. Unfortunately, none of these badnesses got better with surgery. So the carotid stiffness didn't become really less stiff, the IMT didn't become less, and the plaque thickness did not regress. So in conclusion, we clearly found evidence of cardiovascular abnormalities in the carotid, the aorta, and in the heart. But having found no clear improvements of the cardiovascular indices with parathyroidectomy, our conclusion was that more data is needed, and that we are not suggesting, based on this, that everybody who has this diagnosis go have, carotid studies and echoes and everything else. On the other hand, there may be reason in individuals who have significantly increased cardiovascular risk to consider not wanting them to remain with hypercalcemia and hyperparathyroidism forever and ever. Amen. It is noteworthy because every one of you will have consults from somebody who says, I have a patient, their hypertension is really hard to control, don't you think they should have a parathyroidectomy and get rid of their hyperparathyroidism? We know that the association is common. These are two relatively common diseases. We know that the association is causal in people with MEN, but there is no evidence of causal association in sporadic hyperpara. It may be a statistical association. It may just be two common diseases. And thank goodness we now actually have RCT data that addresses this question in the form of the wonderful Scandinavian RCT that I referred to before from Bollerslev et al. 3 countries, 191 patients. And this is the 2-year data looking at where they looked at other cardiovascular markers, but also looked at blood pressure. And what you see here is that the dotted lines are those individuals who were randomized to observation. The black line is those individuals who underwent parathyroidectomy. And what they found was that blood pressure went down if you had surgery. And so that's really great. The problem is, and this is one of the problems with not having an RCT and just looking at observational data, those individuals who were randomized to no surgery also had better blood pressure at 2 years. And so the appropriate conclusion is, from this data, is that being in a study is good for your blood pressure, not that surgery is good for primary hyperparathyroidism blood pressure. Okay, so it's really important because seems to be a message that even our medical colleagues, not only the surgical colleagues, just don't get, that it just is not going to make everything better, and they will still be on 3 drugs in all likelihood unless something else changes. So in addition to these things, BMI didn't get better, glucose and lipid metabolism didn't get better, adipokines didn't get better, inflammatory markers didn't get better, and the markers of endothelial function didn't get better, which is all unfortunate, but it's just important. That's not to say that I'm actually a tremendous proponent of surgery for patients who have primary hyperparathyroidism. It's just important to manage expectations and to be able to clarify in your own minds why you're sending somebody for a procedure and make sure that that's correct. Vitamin D deficiency obviously is a huge issue. When I first started looking at patients with these studies, and when I first analyzed our cohort, 84% of all of our patients had Ds under 30, and over half of our patients had vitamin Ds under 20. But that has changed, as with D supplementation in every other regard, that we no longer see that. But in that initial cohort, what we found was that those individuals who were in the lowest tertile of vitamin D also had the highest PTH levels. And those who had the best PTH vitamin D levels had the lowest PTH, or the ones closest to normal. And so that suggests that there is a secondary hyperparathyroidism superimposed on the primary hyperparathyroidism due to vitamin D deficiency. What has changed is a remarkable difference in the prevalence of vitamin D deficiency, at least in New York City, where people read the New York Times, where they are bombarded on a regular basis by articles that say, take vitamin D, you will have a lower incidence of breast cancer, you will have a lower incidence of colon cancer, you will have a lower incidence of heart disease. So everybody is popping vitamin D, and as you can see now, over 80% of our, over 60% of our patients have vitamin Ds over 30, and actually very, very few patients are profoundly vitamin D deficient. And only about 20% of our patients have vitamin Ds under 20. So we are not seeing D deficient cohorts. The profile has really changed. And along with that, the mean levels of PTH have declined significantly. So whereas in our earlier cohort with a mean of 20, the PTH was 120, and now with a mean vitamin D of 37, the mean PTH is only 15 picograms per ml above the 10 picograms per ml above the upper limit of normal of 65. The 2009 and 2014 international guidelines say that recognizing the increased importance or increased understanding of the importance of not being vitamin D deficient, that all patients with primary hyperpara should have 25 Ds level measured, and if you're have a patient with a level below 20, replete it. They do nothing to help you understand or know how to replete it, and that's because we don't have the data. The data are mainly anecdotal and from small studies. This is a study from Gray et al., the people down under, where they put people on 50,000 international units a week for 4 weeks and then 50,000 international units monthly. And what you can see is that the vitamin D levels did go up and the PTH levels went down, presumably by the amount that represented the secondary hyperparathyroid response. They did have patients, one patient out of the 21 who became very hypercalcemic, and 4 of the 21 who became very hypercalciuric. And so exactly how to do this safely, particularly if you have a patient who is starting out with a urinary calcium that's on the higher side, is really not known. We have been trying to enroll into an RCT to look at this for the last 5 years, and if any of you are close enough to send your patients our way, we would be extraordinarily grateful. We need 10 more patients this year. Again, there are no guidelines for repletion, and if you look at some of the studies or if you talk to your surgical colleagues, people are doing it every which way. And in some of them are, I talked to somebody who gives 200,000 units on a one-shot deal just before surgery. I mean, that's great. You hope for the best, but we don't actually know what that does, and certainly there's no data on how to predict what that does in a given patient. Normocalcemic primary hyperpara, probably on everybody's mind more than the hypercalcemic variety. We first postulated that this was something that probably existed because when hypercalcemia is first detected, the changes in bone density, particularly the declines at the radius, are already there. So we hypothesized that there must be some earlier phase of the disease in which hypercalcemia was not detected, and it sort of made sense as things are happening and the parathyroid is growing, that the PTH would become high, and then it would have to get to a certain amount of high or a certain critical cut point before it would be associated with enough calcium being pulled out of the skeleton to translate into hypercalcemia. But we started seeing more and more and more of this in the context of bone units or endocrine units, where people were coming in not because they had a problem, but for health surveillance because mom had postmenopausal osteoporosis, or they had an x-ray and somebody said it looked demineralized. And so in these context of these programs, bone density, PTHs, calciums would be drawn all at the same time. And for the first time, we started to see patients who were normocalcemic and had hyperparathyroidism. In the 2008 consensus conference published in 2009, the definition was given and was affirmed again subsequently that it requires a normal, not only total calcium, but normal ionized calcium. There is no reason to draw an ionized calcium on a patient who's hypercalcemic, because if it's high, it's high. But in those patients in whom normocalcemic primary hyperpara is a considered diagnosis, it is an appropriate thing to do. And if the ionized calcium is elevated, since that is the biologically active component, then you do not have normocalcemic primary hyperparathyroidism. In hypercalcemic primary hyperpara, you can have a normal PTH. If the PTH is normal but the calcium is high, then that's not normal, right? PTH should be suppressed. But you can't have a normal total calcium and a normal PTH and call it normocalcemic primary hyperpara, because something's got to be normal, or else if you have two things that are normal, you're probably normal. Can't imagine how many people I have argued, need that explained carefully. But anyway, the other thing that's absolutely essential is that you rule out secondary causes of hyperpara. And in fact, most patients who come in with the biochemical picture of normocalcemic primary hyperpara, normal calcium and elevated PTH, have coexisting vitamin D deficiency. And when you treat the vitamin D deficiency, the serum calcium drifts up through the top of the normal range, and they actually have garden variety hypercalcemic hyperpara, but the D deficiency was just pulling the calcium down into the normal range. Malabsorption, celiac disease, hypercalciuria, medications that alter calcium homeostasis, all can do this. So in order to feel comfortable about this diagnosis, all of those things have to be rigorously ruled out. The natural history is a pain, because there isn't a natural history, a single natural history. So we were interested in following these people because we wanted to know how many years it would take for them to become hypercalcemic. And we published our first study after 4 years, and then again after 10 years, and there is no single natural history. And some patients become hypercalcemic a year after they are recognized to have this, and some 3 years, 4 years, 5 years, 10 years, and some at 10 years are still exactly the same. So there is no single time course, and not all patients actually will become hypercalcemic. And so these patients may have existed like this from time immemorial, but we wouldn't have known about them. So more data are needed in terms of predicting what's going to happen in a given patient. What to do about it, you all know that surgery is the only option for cure. It was then, it is now, and so part of the question is what happens to patients who have surgery. Gives me an opportunity to say that preoperative localization is not necessary if a four-gland surgery is contemplated, but is absolutely necessary if a minimally invasive procedure is contemplated. Whenever there are millions of choices on a list for how to do things, that's because no one of them is perfect. And that's clearly the case in this situation. So cestamide with SPECT is probably the most commonly done procedure. Here we do cestamide with CT with and without contrast. It really depends what is best in your center, because what people do best is the way that it's going to be best done. The bunches of surgical options, as I mentioned, the important thing to point out that in order to do a minimally invasive parathyroidectomy successfully, intraoperative PTH measurement is a necessary adjunct. Much of the observational data and the longer term data that I'm going to be presenting comes from our cohort. This looks like a randomized study, 60 in each. It's not. It's just by accident. So we have people in The surgery group who had very mild disease met no criteria and just wanted it out, and we had people in the no surgery group that I'm sure you all have in your practices who meet every criteria and no way are they having surgery unless it's an absolute emergency. So the nice thing is that the short-term RCT data from the 3 RCTs that I've shown you before are very similar. So biochemical indices get better after surgery, not surprisingly, and BMD improves. We did not predict that this would happen, but as you can see, over a long period of time, they do not lose bone, and in fact, they increase their bone density very nicely in the early postoperative period at the spine and the femoral neck, and at the forearm, less so initially, but eventually there is a nice increase. In those individuals who have bad bones at the spine, early on, who have, in this study, we were actually using z-scores, had a cutoff of a z-score of minus 1.5 or worse. What we found was a marked and actually greater improvement. So the worse off you were at the spine, the more bang for your buck you got by having surgery. And as you can see, the mean increase at 1 year was 15%. At the lumbar spine. And these were the data that led to the inclusion of the guideline that anybody who has osteoporosis should have parathyroidectomy. Yes?
Should we be using trabecular bone score to make more people meet surgical criteria?
There are no data on using trabecular bone score as a cut point for surgeries. So we still use DEXA data. And I'll talk about that in a minute. So HRP-QCT also gets better. I already showed you that the TBS gets better. This is the same person before and after parathyroidectomy. And what we see is that the trabecular bone clearly gets better, and not only that, it's translated into mechanical competence because the failure load changes. At the tibia, the same is seen. So does fracture risk fall? There are some data that suggest that it does, but it's not definitively known. The data are observational. So what about people who don't have surgery, with the subtext being, is it safe to follow people? In a small subset, calcium gets worse, but in a large group of people, calcium sort of stays the same. So the patient who comes in with a calcium of 10.5 is not all of a sudden going to have a calcium of 12 unless they have other intercurrent illness or something like that. Bone density tends to stay stable, at least for the first 5 to 10 years, but thereafter, the cortical sites have a significant and marked decline. So it's just in the first years. Of course, this is, again, sort of amazing because these people started out at a mean age of 61 and they don't lose bone during the first couple of years after the diagnosis. So of our patients, we found that about a third to 40% have evidence of progressive disease in as much as they developed one or more new guidelines for surgery over the course of observation, and bone density does start to decline. So infinite observation in somebody, especially somebody who's young, is probably not a good idea. So where are we in terms of the latest international guidelines? The first question was, should the diagnosis be changed? And the answer to that was no, that normocalcemic hyperpara was reaffirmed. Either a second or third generation PTH assays are fine. There wasn't any particular reason to say one assay is better than the other for making the diagnosis. Is there evidence of specific benefits with medical therapies to recommend their use? And basically, phosphates on this list to remind me that you all should know to never use phosphate. There will be people who will send patients in from the community because in the old days they gave phosphates to lower calcium. Not a good idea. Estrogen works. So just because the Women's Health Study made it so that all postmenopausal women are no longer on estrogen, if a postmenopausal woman decides to take estrogen for symptoms of menopause and they happen to have hyperpara, one can expect that their serum calcium will decline slightly by up to 0.5 milligrams per deciliter, and their bone density may get better, because these are data that came from before. What happened was around the WHI outcomes, everybody turned their brain off and forgot that it still actually works for those people. Raloxifene, Michaela Rubin, who I'm sure has talked to you already, when she was my fellow, she did a wonderful RCT short-term looking at raloxifene and found a decrease in bone turnover markers. It didn't go on long enough, and a decrease in serum calcium, similar to that seen with estrogen. Again, not something you would use for that purpose. Bisphosphonates do increase bone density, and here's a study showing that with bisphosphonate users in the blue bars relative to the placebo users in green, a small RCT showing that bisphosphonates work in patients with hyperpara as they do not in patients with hyperpara. But there really is no change in the serum calcium. So we were hoping that, as with the other bisphosphonates, that we might see a decrement in serum calcium, but that is not shown to be the case. So that although it's not FDA approved for the use in hyperpara, in those hyperpara patients who can't or won't have surgery and who have low bone density, the bisphosphonates are an option to address that particular issue. The calcimimetics were something that we were very hopeful about because we thought they would fix everything, and that they would be the equivalent of a medical parathyroidectomy and take care of, God bless you, all of the issues that are seen in primary hyperparathyroidism. And in fact, they have been shown to normalize serum calcium over a prolonged period of time in cohorts that have very mild disease, and the lowest bars just in the mid-10s, up to people with really bad disease, serum calcium's approaching 12. They can all be normalized using Sensipar. PTH does not normalize, and hearkening back certainly to some of the cardiovascular data that suggests that they're more associated with PTH than with serum calcium, and so that that's already suggestive that some of the other things may not be addressed using the calcimimetics. But similarly, there's no improvement in bone density with 4 years of calcimimetic use. So certainly there's one of the main reasons to undertake parathyroidectomy in a patient is not to be expected as a result of using calcimimetics. It is, however, well tolerated. The data on stones is very limited. They also looked at SF36, which did not improve with the use of this. So in a very, very selected group of patients who are very hypercalcemic and can't have surgery or won't have surgery, this may be something to try. But I think that in my entire practice, which is made up at least predominantly of hyperpara patients, I have 2 people who are on Cinacalcet right now. It's not something that I use in a wholesale way, nor does anybody else in our bone group. Should the guidelines for surgery be changed in light of new data? The first thing we did was affirm that anybody who had classical symptoms of hyperpara should be sent for surgery. The first guideline was the degree of elevation of serum calcium. And it should be noted that 1 milligram above normal was never based on any evidence that 11.2 is different from 11.0 or 11.3 or anything like that. But basically, there wasn't any reason to liberalize it or particularly to make it tighter than that. The renal guidelines did change. The 2008 guidelines took out the 24-hour urine. Truth and confession, I never stopped doing 24-hour urine calciums in patients with hyperparathyroidism because I just didn't have the self-confidence to have a patient with a 24-hour urine of 590 and say, you don't need surgery, we'll just watch you and see what happens. But anyway, the 24-hour urine guideline went back in for ruling out FHH and for assessing stone risk, and if the 24-hour urine is greater than 400, the suggestion is to do a greater stone risk assessment because the nephrologist pointed out that there is no one-to-one association, so that you can have people with kidney stones and a 24-hour urine of 180, and you can have patients with 480 who don't have stones. what was added was to do imaging for renal stones that might be occult. There had been a Japanese study with an incidence of about 15% of asymptomatic stones. And we have initiated imaging studies on all of our patients and are seeing about 15 to 18% of patients with asymptomatic stones as well. And those people we're then referring for surgery. The skeletal guideline had been a T-score of less than -2.5 and fragility fractures. We now have, as of this latest guideline, are instituting a vertebral imaging guideline, which can either be a VFA on your DEXA or a spine film, with the idea that it made no sense, since so many vertebral compression fractures are not recognized clinically. It made no sense to say that if you have osteoporosis on DEXA, you go, but if you actually have a compression fracture, there's no reason to treat you. Yes? Well, those people they already have a history of an overt stone. And so most of those people we do suggest that they have parathyroidectomy, unless, I mean, if the stone happened 30 years ago and then we have 20 years of normal serum calcium levels, that's a different story. In those people, what I would probably do is a stone risk profile, a 24-hour urine with a stone risk profile, and if it's elevated, do it, but not necessarily as a knee jerk. If they had a calcium stone 2 years ago and now they have overt primary hyperparathyroidism, I would send them for surgery. Finally, this relative youth criterion. So in 1990, when it was included, the cut point of 50 was included in the as a criterion for surgery. It was really included just because we didn't have any idea what this asymptomatic disease was going to be like, and if in fact people were going to get much, much worse over a period of time, obviously then you wouldn't want somebody who was young to just hang out with it. And then what happened was we finally had some evidence from following our patients, because as it turned out, we were much better at being persuasive with our patients about the need for surgery if they met the calcium guideline or the osteoporosis guideline or the kidney stone guideline than we were about people who were under the age of 50. And so we ended up with a small cohort of people who were in their 40s or 30s who said, you know, but my hyperpara is so mild and I don't really meet anything that has to do with hyperparathyroidism. Wouldn't it be okay to follow me? And we obviously agreed. But it turned out that when you looked at the people who were over the age of 50 who were followed with no intervention, about 20 or 25% of them had evidence of progressive disease. Whereas patients under the age of 50, 66% of them had evidence of progressive disease. So this was for the first time something that was evidence-based to suggest that, as with other disorders, for instance, breast cancer, when it presents in somebody who's 30, it tends to be a more aggressive disease. There was nothing that characterized them at baseline in terms of their biochemistries or their bones or anything else, but the disease just is a more active disease, and so those people really should be sent for surgery. So that was reaffirmed, and that's where we were at the end of this guidelines discussion. Can some patients be followed without surgery, and if so, how should they be monitored? And basically, we suggested that after an initial period where people are monitored more closely, we reaffirmed annual calciums. 24-hour urine calcium should not be repeated unless stones are suspected. Creatinine clearance calculated annually, the eGFR. Serum creatinine is therefore obviously measured annually. Bone densities as often as you can get them. It was pointed out to us that in other places in the world, it's really hard to get them. So when we were saying maybe every year if you can do it, people who lived in countries where that was a completely impractical public health recommendation, and these were international guidelines, objected. And abdominal X-ray or ultrasound only if a kidney stone is suspected. The special circumstance, what do you do if you have a patient with normocalcemic? How do you monitor them? Basically, again, calcium and PTH every year, DEXA every 1 year or 2 years, as you would with the hypercalcemic patients. If they do progress to hypercalcemic, you treat them and follow the guidelines just as you would with hypercalcemic patients. In those who stay normocalcemic, if they have worsening bone density or evidence of fracture, fracture without being hit by a truck, obviously, kidney stone or evidence of nephrocalcinosis, then you consider surgery, but it is important to remind yourself that this is not based on good data. We really just don't know. So hyperparathyroidism, primary hyperpara is an evolving disease. Today, classical hyperpara is rare in the US, but not so in some other places in the world. Asymptomatic hypercalcemic hyperpara continues to be the most common phenotype that we see. Normocalcemic has become more and more common, and certainly is more and more common in the endocrinologist's office, because internists may feel comfortable referring a classically mildly hypercalcemic and hyperpara patient to a surgeon, but they almost never know what to do with a normocalcemic patient. So we have guidelines that were revised. We know that surgery works. It's relatively easy, and the morbidity is very limited, and it increases bone density. Patients who meet no guidelines are okay to be followed conservatively for several years, but probably not forever. So depending on how people are and how well you do at convincing people of things, it's probably not going to be something where people are going to be followed for decades and decades with no surgery. There's very limited data on the outcomes of surgery or no surgery in patients with normocalcemic disease. And despite efforts, there is no evidence that there is a pill that is going to be the equivalent of a medical parathyroidectomy, at least where we are now. There are still lots of things that we don't know and that we are still working on. We don't know if guidelines apply in normocalcemic hyperpara. We don't know about FRAX and fracture risk in hyperpara in general. There's still many things to be learned about the cardiovascular and neuropsychological manifestations. Dr. Marcella Walker, who I'm sure you've met as well, is currently doing a study doing fMRI localization of the neuroanatomical abnormalities to certain places before and after parathyroidectomy, and also is doing studies where she's measuring vascular reactivity in the intracerebral space to see if the carotid stiffness goes into the brain as well. How do you replete vitamin D? What is the effect of renal impairment? We say that people should have surgery if their kidneys don't work particularly well, but we don't know if the kidneys actually get better or if this accelerates kidneys getting worse. And what to do with pharmacologic therapy, particularly in patients who are on a bisphosphonate, and at the time of surgery, should they be stopped? Should people initiate surgery? We really just don't know. And so there's been a huge amount of data that has come out over the last several decades, and there still is a bunch more to come. And with that, I'll stop and take any questions you might have.